So good afternoon, one and all. I invite you all for the IC, an enigma of filtering blab, strike when blab is hot. So this IC will insight you intra-op, pre-op, and the post-operative management of the trabeculectomy. Everyone do trabeculectomy, but doing a trabeculectomy is quite simple procedure. But managing a post-operative management of trap really is still an art or a kind of skill you required how to manage your blab post-operatively. It needs lot of modifications, lot of intervention during 1.5 month. So this course will guide you thoroughly with help of some video sessions and the experience of the expert. We have galaxy of speakers having the vast knowledge in their field. So first of all, I'm going to invite Dr. R. Ramakrishnan. He doesn't need any introduction. He is a mentee of many mentors, and he is a chief advisor of Arvind Eye Hospital, Tirunelveli, and he is my mentor too. It's my privilege and honor to invite him to share his 35-year experience of trabeculectomy. To RK sir.
Thank you, Devendra, for the opportunity, and good afternoon, friends, and of course, the other faculty, Dr. Ravindra and Dr. Indra. It's a post-lunch or lunch time. Everybody is in the queue for lunch, and also most of us are in the trade. That's why we are having a very less number of audience. Anyway, so this session, of course, is one of the important sessions. As Devendra mentioned, doing trabeculectomy is not at all a difficult task, but how to manage or how to make the surgery to work forever, that's very, very important, because that depends upon how you preoperatively evaluate the patient, how you do surgery, and how you manage post-operatively. That's a very important thing. And of course, I am going to talk about the preoperative evaluation and also preoperative preparation and also some of the intraoperative tips that will help the trabeculectomy to work forever. Of course, all of you know very well the aim of the glaucoma therapy is to protect and prevent damage to the optic nerve head and preserving the visual field function. And of course, glaucoma is a surgical disease. Most of the glaucoma is a surgical disease, and it's also the even collaborative initial glaucoma treatment study proves that surgery is better than medical treatment. And of course, trabeculectomy with the anti-metabolite, especially mitomycin C, is the gold standard for surgical management of glaucoma. And even though we have so many types of anti-glaucoma surgery in the recent past, including non-penetrating filtering surgery or minimally invasive glaucoma surgery, sorry, and shunt, still trabeculectomy continues to be the most commonly and also most frequently performed surgery for glaucoma worldwide. And because the success of trabeculectomy also depends upon what are the indications for to indicate the definite type of glaucoma, as a primary glaucoma or secondary glaucoma or something like that. And also other main indications are failure of medical therapy, intolerance to medications, and advanced disease and disease progression. And of course, some of the other important indications, especially in developing countries like India, and also socioeconomic condition is one of the important things. And the systemic contraindications for anti-glaucoma medications. And also, when the rate of deterioration of visual function is rapid enough to damage the patient quality of life. That's also one of the indications. And the contraindications, especially blind eye, when there is a presence of active inflammation, neovascularization, and whenever there is extensive scarring of the conjunctiva, we should better to go for some other modality of treatment. Why preoperative evaluation is important? Because to obtain a satisfactory results in surgery, and you have, as I mentioned, the specific patient group different types of patient or different types of glaucoma with so many systemic medications. So they behave differently during surgery. And also we have to identify the high-risk patients and give more importance for that patient. And a good interaction between the patient and surgery is very, very important because it's not like cataract. Cataract, you just do, and next day patient will read 6/6, and you forget, and patient is happy, and you are also happy. But trabeculectomy is not like that. It is, we are doing surgery in a seeing eye, and most of the time, after surgery, for about minimum 1 or 2, 3 months, the patient will not read the pre-operative visual acuity. Suppose if you are operating 6/6 trabeculectomy, next day the patient will be reading 6/24, 6/12, or something like that. And to have a 6/6, it will take 2 to 3 months. Sometimes it may remain 6/9 or something like that. So a thorough, good interaction between you and the patient is very, very important, and explain about the disease to the patient and also evaluate the other medical conditions like diabetes, hypertension, any other thing, and also history of systemic and ocular medications and determine the risk factors, and also the always better to discuss the procedure what we are going to do with the patient, and also explain about the important complications that can happen during surgery or after post-operative period. And another important thing is the outcome, because as I already mentioned, the patient, for patient, any surgery is a cataract surgery in the eye. So they will expect more. Even if you combine with the cataract surgery, if you are putting a very expensive lens, the patient will expect everything to be normal. That's why we have to tell what they have to expect. Unrealistic expectation that should not be there with the patient side. So we have to give a thorough counseling, and patients should know what to expect. Always there should be a bilateral cooperation between the doctor as well as the surgeon, and we should not force the patient to undergo trabeculectomy. Always it should be a bilateral decision. And also we have to all the time tell the patient the surgery is not to improve their visual acuity or quality of vision. It is mainly to reduce intraocular pressure and also to prevent further loss of sight. And of course, about the counseling about the disease and what you are planning to do, and also do not give false hope also. That's very, very important. And also we have to explain about whenever you do a surgery for advanced glaucoma, explain about tell about what are things that are going to happen, washout or something like that. Consent is very, very important. You have to get a good consent from the patient as well as his relatives. And also main aim is to have a very good successful filtering blab. And these are some of the important complications. Because suppose unless you know what are the complications, it's very, very difficult to perioperative or intraoperative to plan for surgery. So one of the important complications is failure, then of course wound leak and hypotony, leading to hypotony and other hypotony maculopathy, and of course blub related problems like blebbitis, blub leak, etc. All these things we have to keep in mind. And this can be avoided, all these complications can be avoided with preoperative planning and modification of surgical procedure and appropriate post-operative management, and of course frequent follow-up. So how to prepare for trabeculectomy? As I mentioned, all these things should be happen, and also we have to examine the tear film status. Suppose the patient is on long-term anti-glaucoma medication, definitely there will be sub-abnormality of the tear film, so we have to treat with a tear supplement, and also what are the anti-glaucoma medications the patients are taking. And then, of course, we have to give a detailed attention to all these structures before doing surgery, and of course, presence of inflammation, and the lens status, whether phakic or aphakic and pseudophakic, all these things are important. And then, of course, enhancing success. Two things during surgery is one is the use of antimetabolites depending upon the indications, and also post-operatively we have to give topical steroids, and also, as you point out, Depending upon the situation, we have to do digital massage, laser suture lysis, release of the releasable suture. And of course, the scleral flap is again one of the determining factor in the success of the trabeculectomy. One other important thing in doing trabeculectomy, so practically what we are, every patient nowadays, most of the patients, general patients, they have diabetes or hypertension, cardiac. They will be on, sometimes normal patients also taking disprin or clopidogrel and warfarin. So we have to ask for the history and we have to stop them at least for 5 to 7 days with the opinion from the physician. And also a good control of hypertension is very, very important to prevent intraoperative bleeding. And also discontinue anti-glaucoma medication. Why? Because long-term use of anti-glaucoma medication will alter the conjunctival cytology. There will be increased conjunctival hyperemia and also increase in fibroblast and gallbladder cell will come down. And another thing is breakdown of the blood-aqueous barrier and also tape film changes, as I all mentioned. So this will cause increased inflammation, fibrosis and scarring of the filtering bleb and leads to the failure of the filter. And that's why we have to use topical. We in our hospital for quite a long time, more than 20 years, we are using topical steroids. Those who are on long-term anti-glaucoma medication, we will stop them and give weaker steroids like fluorometholone, FML or dexamethasone about 4 times daily, 5 to 7 days before surgery. And the eye will be perfectly all right. There will be no congestion, like conjunctiva will be healthy. And definitely there you can see the, appreciate the changes with and without the steroids post-operatively. Definitely this will decrease the number of conjunctival fibroblasts and also inflammatory cells and increase the gallbladder cells. And there are so many studies also have been done and also decreases vascular congestion and stabilizes the blood-aqueous barrier. And what are the indications? Whenever the patient is on long-term anti-glaucoma medications and in inflammatory glaucoma, VVT glaucoma, better to give pre-operative steroids, either topical or oral or parenteral, and also in acute congestive, following acute congestive glaucoma. And this reversal of this conjunctival cytology after topical steroid therapy. The pads for a good outcome in trabeculectomy is good anesthesia and kinesis, very, very mandatory. Minimum bleeding. There should not be any bleeding. That's why I told you to stop antiplatelet and also to control the hypertension and the low vitreous pressure and the comfortable patient and the meticulous handling of ocular tissue, including the conjunctiva, iris and trabecular meshwork, etc. And judicious use of mitomycin. That's very, very important. There is no hard and fast rule that we have to use certain amount of concentration of mitomycin. This all depends upon the indications, whether the patient is young or old, or also the status of the conjunctiva and type of glaucoma, and also how long the patients are using anti-glaucoma medication. All these things are important before determining the concentration and duration of exposure of the mitomycin. And also definitely a good control of intraocular pressure before surgery with all means, whether with the Dimax or oral glycerin or intravenous mannitol. You have to have a good control of intraocular pressure so that the surgery will be uneventful. And the surgical technique is, of course, a good anesthesia is very, very important, and a good lid separation to have a very good exposure of the surgical site, especially when you do a superior rectus bladder suture or clear corneal traction suture. We use both, but always better to do on ourselves instead of asking the nurses to do it. And also, you can have so much of complication when you do superior rectus, so you have to know how to hold the superior rectus muscle, and because sometimes you may end up with severe bleeding and hematoma, adequate hemostasis, and gentle tissue handling, as I already mentioned. Anesthesia, any type of anesthesia you are comfortable, or even topical, you can do topical with a little bit of conjunctival, subconjunctival infiltration. We can very well do in a cooperative patient. We need not go for subtenons or peribulbar, retrobulbar injections. But so whenever you do a surgery in peribulbar, retrobulbar injection, don't immediately take up for surgery. Give adequate time for the anesthetist to act, and also adequate time to eye become soft and quiet. Suppose if you give 5 to 6 ml into the peribulbar block and immediately if you take up for surgery, there will be so much proptos and you will be tense, and then you will end up with the problem. So always better you wait, and also use of adrenaline, we have to be very cautious, and don't repeat the block, otherwise the volume will be more. The points to be remembered is especially when you add adrenaline, large amount of adrenaline, large amount of salic, that will compromise the optic nerve, the blood flow. That's especially advanced glaucoma, we should be very careful. And also the digital compression, always better not to use a super pingy or a Fresnel's balloon. Always do a gentle digital massage is more than sufficient than with all these gadgets. And also inadequate anesthesia, we have to be very careful. The anesthesia of the patient is so comfortable in the table, and repeat blocks should be avoided. These are the key surgical steps. Each step is very, very important for the success of the trabeculectomy post-operatively. Two things. One is, as I mentioned, antimetabolite, then scleral flap formation, and of course the suturing of the scleral flap, either fixed suture or releasable suture, and then forming the AC and look for the patency of the ostium. And of course, conjunctival, 2 minutes. Incision, previously what we used to take limber-based flap for all our trabeculectomy. So what we come across at that time, it's, we had a lot of, because the blub is so much of localized blub, and you have what you call as the ring of steel phenomena. This is what you call as the, whatever amount of itemization used, the blub area will be avascular. But surrounding that area, there is a condensation of the fibrovascular band around this blub, and this will restrict the flow of aqueous humor posteriorly. So you will have a localized blub. That's why the Moorfield people have modified this technique into, they have, instead of going for limbal base, they advocated phonics-based conjunctival flap. So in that, what we can do is you can undermine the conjunctiva, and you can put the mitomycin sponge much more posteriorly, so that you will have a diffuse bleb. Instead of a localized elevated bleb, you will have a diffuse, moderately avascular bleb, and the patient will not have any bleb-related complications, bleb-related symptoms. That's the main advantage of phonics-based flap. And of course, antimetabolite is always nowadays, Devendra is using mostly 99% now injection mitomycin. Depending upon the case, the concentration varies. Minimum, commonly we use 0.2 milligram per ml, 0.1 ml with xylocaine in the small 48 millimeter forceps to the limbus. We inject and wait for few minutes, and then we will do the surgery. But commonly, sponges are used ranging from 0.2 to 0.4 milligram per ml. That all depends upon the type of glaucoma, and also the whether it's primary glaucoma or secondary glaucoma or something like that. So to conclude, a thorough pre-operative evaluation is playing a major role in the success of the trabeculectomy. That's very, very important. And also modification of some of the techniques like the phonics-based flap, and also the use of mitomycin much more posteriorly, and adequate ostium, and also doing paracentesis to reduce the pressure. A gentle, controlled paracentesis is very, very important to prevent the sudden anterior forward movement of the lens diaphragm. All these things are very, very important to have a uneventful post-operative period and successful trabeculectomy. Thank you very much for your kind attention.
Thank you, Dr. R.K. sir. It's an excellent, thorough talk, as always. My next speaker is Dr. T. Ravindra. He is the head of the Glaucoma and Cataract Department at Shankar Eye Foundation, Vizag. He has a vast experience in dealing with cataract and glaucoma. And he is speaking on an understanding of wound healing and producing factor predisposing risk factor. Over to you, Dr. Devendra sir.
Thank you, Dr. Devendra. Thank you, RK sir. Thanks to all the audience for being present on this afternoon. Wound healing is the key requirement for a successful glaucoma surgery. Proper wound healing is to be not too much and not too less. Too much healing will result in failure. Again, pressures will increase, and if the healing is impaired, then it may lead to hypotony and its complications. Not just for trabeculectomy. The trabeculectomy is the gold standard, but even for the other glaucoma procedures, the scarring is a key factor. Means it should be controlled and minimized, and then only the success will come. Otherwise, even the MIGS can become MEGS or minimally effective. So the aim of a proper glaucoma surgery is to maintain the pressures within this green zone. If the pressures increase towards the orange or red zone, again the risk of progression is there. And if we are able to maintain the pressures of the eye for 10 years in the range of 10 millimeters, then only the gold standard will really be gold. And it is possible only with further advances to the techniques of control of healing, control of wound healing. To be understood in detail, active inflammation that is seen by the red color of the vessels is something that we see externally, but internally it is all microchemicals. Microscopically active factors are involved, and we have to understand that inflammation is one thing that occurs immediately, that is a phase 1, and fibrosis is something else that starts at around the day 7. And both these require distinct approaches. Some of the cell culture treatment studies have shown that the fibroblasts become more active in the presence of macrophages. Therefore, we have to understand how to control the macrophages in the initial part of the surgery, and then how to minimize the contraction of the fibroblasts in the later on phases. So intraoperatively, the surgical technique is important, the pharmacological adjuvants are important, and if we are using the physical spacers are important. And post-operatively, how we use the steroids, how many weeks or months, and then at the appropriate time, what we do about the digital or ocular compression and compression sutures, suture lysis. The decisions related to these are very important for a successful modulation of the wound healing. Now coming to the preoperative factors, the duration of treatment that has been there before the surgery has been undertaken is very important. How many molecules were there, and what was the vehicle, means whether it was affecting the macrophages level and cytokine levels in the conjunctiva. That is very important, and the resulting conjunctival deterioration can affect the outcomes adversely. And so whether the holiday to the medicines, to what extent it can be given, and whether the steroids are used for 3 days, 5 days, or 15 days, those factors also ultimately lead to resulting conjunctival improvements and are very important for improving the outcomes. So there are studies on tear film molecular biology which have been done, and in the complicated cases versus the normal cases, and altered frequency and amount of the immune response related markers have been done, and it shows that these factors are really very crucial for the success of the surgery. And per-operative factors that are very important include the surgical technique, the anti-inflammatory agents, antifibrotic agents that we have used during the surgery. And post-operative wound healing related modulation is also very important. The modifications include single scleral punch sclerostomy, flap not being cut to the limbus, adjustable sutures, large treatment area with antifibrotics, and many other factors which have already been dealt with and will be dealt with later on, and consequently the bleb function and morphology can improve. The spacers which are implanted, like the Ologen implant, is a potentially useful implant, and it is very important to understand that it is probably the safety improving factor and not just success improvement factor as of now. In the post-operative phase, the 5 fluorouracil injections are very important, and whenever they are to be used to the optimum level, neither less nor more. And with the current experience, the failing blebs are improving very well with the 5 fluorouracil injections given at the appropriate time. And now the role of aqueous humor flow is also important. How the aqueous humor related flare differs with a plain trabeculectomy versus a cataract surgery has been studied, and this is one of the things that really shows how the combined surgery outcomes may differ from the trabeculectomy alone that has been taken up, and how the steroids are to be given is important, because otherwise the scarring will again start and increase. Another important factor is that hydrostatic pressure of the aqueous humor created by the aqueous fluid is to be understood, and therefore in the initial period of the post-operative phase, the pressure should be under good control. Otherwise, what will happen is that the hydrostatic pressure related factors will lead to increased scarring. So these are studies done with tube surgery, and this experience is also reflected by our modification of trabeculectomy related protocols. So keeping the IOP low in the early post-operative period by good control of the sutures, appropriate timely intervention of releasable sutures or laser suture lysis or bleb massage is very important aspect. Otherwise, the hydrostatic pressure related vicious cycle will start, and they will lead to scarring and ring of steel like appearance. Now, so many other factors are being studied. Although much research is required, the research is not yet complete, and therefore, probably in the next coming years, more and more discussions on these aspects like TGF-beta receptor kinases will be coming into our discussions. And someday we may be able to predict the risk factors of scar formation after glaucoma surgery based on patient's own genetic profile. To summarize, the quest for bleb to be perfect is on, and with surgical techniques and healing modulation, the effective surgery will definitely come in the future. Thank you.
Now I invite next speaker is Dr. Amit Porbal. He doesn't need any introduction. Everybody knows him. He's a member of Scientific Committee Chairman. He's the head of the department of Choithram Eye Hospital. And he is having the vast experience in glaucoma surgeries. And he is speaking on early intervention, ocular massage, suture lysis, or injection MMC, when and how. Over to you, Amit sir.
Just 1 minute, Devin. I think they are. You all don't monitor the slides from there, I'll monitor from here. So thank you, Devin, for making me part of this important course. And my mentor, my teacher, Dr. R.K. sir is here. I have got a lot of important tips throughout my career when I started practicing glaucoma from him. And my colleague Ganesh, Devin, everybody, we all work together as a team. When we are in different parts of the country, we do consult one another. So thank you once again, Devin, for making me part of this course. So I'm going to talk on early interventions, that is ocular massage, suture lysis, when to give and how to give injection antimetabolite like MMC and 5FU. So we all know that failing bleb is basically a bleb which has an increased vascularity. They show corkscrew vessels. There's a high IOP in the 1 month. In the first month, there's an encapsulated high dome appearance. They can be flat and localized, and there can be absence of microcyst. So raised IOP with deep AC, how do you go ahead? The causes can be due to internal obstruction by blood, fibrinous clot, iris, or vitreous. There can be an ocular cause of excessive fibroblastic proliferation, and there can be an extraocular cause of tight scleral suture. So whenever you have an uncontrolled IOP and a deep AC, always do a gonioscopy first. Look for the obstruction to the flow at the sclerodermal site. The obstruction with mild fibrin and minimal blood is transient and does not need any intervention. But if the internal ostium is obstructed with iris, vitreous, incarceration, or dense fibrinous membrane, then you have to consider laser internal revision or surgical intervention. If dense blood or fibrinous clot is occurred in the fistula, then you can consider tissue plasminogen activator. Coming to the next protocol, managing the failing bleb is basically a digital ocular compression. It is done in the early post-operative period when the IOP is elevated and the bleb is flat. It separates the edges of the scleral flap by expanding the subconjunctival space and decreases the IOP and elevates the bleb. It is not effective in blocked fistula. So what is the technique? A slow and steady pressure for 15 seconds is applied with the index finger. It can be given to the inferior sclera through the lower lid or the sclera posterior adjacent to the bleb through the upper lid. You can do a focal compression with the moistened cotton tip applicator, applicator at the edge of the scleral flap. So it's a small video of how to do a bleb massage. But this is very, very important whenever you are doing a bleb massage. You have to make sure that you observe the bleb also. So this bleb was flat and it was 1 week post-op. So I'm trying to massage through the upper lid at the posterior edge of the bleb. And you can see as I'm massaging, you have to keep an eye on the anterior chamber also. You don't want the sudden gush of the aqueous fluid. You have to be gentle when you are doing it. And you have to see that there is no hypotony and the AC doesn't collapse. So as you are giving the bleb, giving the massage, you see that the bleb is being formed because of the aqueous drainage. But you have to be very careful. There can be a pseudo appearance also. So when you're doing the massage, the lymphatics get obstructed and you feel that the bleb has enlarged when there's a conjunctival edema. So you have to make sure that you differentiate between this conjunctival edema due to the blocked lymphatics and to the bleb which is formed due to the aqueous drainage. So this is the way, one of the ways which I am showing in this video. The other methods you have already seen. So always keep a track on the anterior chamber depth and on the bleb when you are doing the massage. So when you have an AC depth, you should always look at the AC depth, the height of the bleb and the IOP. If successful, the bleb massage is successful, then it has to be repeated several times. But if the IOP remains high, then what do you want to do next? You could do removal of the releasable suture if you have put the releasable suture, or you are going to do laser suture lysis. Now, releasable suture, we all know the technique. This has been a standard care when you are going to do a trap surgery. A trap surgery with a releasable suture is the surgery of choice nowadays. So, putting a releasable, this video is showing, but I'm not going to go into the extremes of how to put the releasable suture. But what is important is the removal of the releasable suture. You can see in this video on the right side that the releasable suture, it has an exposed end on the cornea near the limbus. So you can release it with the help of a 26 gauge needle. Now the thread is released, or you can just take a plain forceps, hold the suture or exposed end of the suture, and gently pull it out so that the shoelace knot which is tied in the releasable suture gets released, and then they can do a gentle massage and the bleb can be formed. So releasable suture is a very good technique. Otherwise, you can do an argon laser suturolysis. In this, all these things, whether you do a releasable suture release or the argon laser suturolysis, the timing is very critical. If it is effective within the first 2 weeks after surgery without an antimetabolite. But when you are using an antimetabolite, it is effective for several months after the surgery. You have to use a conservative stepwise approach. If you put 3 sutures, you don't try to cut all the sutures in one go. You cut one suture, do the bleb massage, titrate how much is the bleb formation, how much is the IOP reduction, and then go for the next suture. So you need not do that, you have to cut all the 3 sutures. So one suture is cut at the time, and what is the technique? You can use a topical anesthesia, you can use one of these lenses, that's the Hoskins lens or the Rich lens. These lenses basically flatten and blanch the overlying conjunctiva. Also, you can use the central button edge or the Zeiss or the Sussman lens, which we are regularly using in our OPD for the diagnostic purpose. A 50 micron spot size of 0.1 second duration, the power variation being 200 to 500 megawatt, and you can give the laser shots. So this is a video which was shared by Devin, because the earlier video was not clear, so I told him that he had this video, and it's very nice. It is nicely demonstrated how this lens blanch the conjunctiva and the suture is exposed, and how you are going to aim the aiming beam of the laser over the suture. It is not that only one shot and you can get the suturolysis done. You will be needing multiple shots, and then you have to titrate the energy to cut the sutures. So once the suture is cut, then the whole thing is very easy. You just give the massage and the bleb formation starts, provided your fibrosis is not very dense. If the fibrosis is dense, then this also is not going to work. Then you go to the next stage, which Devan is going to talk in his later thing. So you can see once the suturolysis is done, a massage is being given, and you can see this is a flat bleb, and how the bleb formation has occurred after the massage. It's a very nicely depicted. The AC is still well formed. You can see the nice bleb formation superiorly. This is the bleb which is formed after the laser suturolysis. So rapid wound healing response, basically the subconjunctival fibrosis is seen. The incidence of failure is approximately 20% because of this cause in the early post-operative period, and 30 to 50% in the late post-operative period. So you have subcutaneous encapsulation of the bleb, which usually occurs in the first 6 months after the surgery, and is seen in 10 to 20% of the patients after trabeculectomy. So what are the antimetabolites which are available and which we are going to use in our trap surgery to modify the wound healing? It basically mitomycin C and 5-fluorouracil. Both these molecules basically inhibit the fibroblastic proliferation, but they act in different cell cycles. So mitomycin is 100 times more potent than 5-FU and kills all the cells regardless of the phase in the cell cycle. You can give subconjunctival injection of 0.02 to 0.04 milligram per 0.1 ml. This dose is very important. It is 0.1 ml and it is 0.02 to 0.04 milligram. I'm stressing on this because mitomycin these antimetabolites are toxic, so you should know the right dose, when to use and how much to be used. You can also use a topical drops of 0.02% 4 times a day for 2 weeks. 5-FU basically inhibits fibroblastic proliferation. It kills only the dividing cells. You can use subconjunctival injection of 5-FU, that is 5 milligram per 0.1 ml. Total dosage being 15 to 50 milligram in 3 weeks' time. You always watch for bleb features, the corneal complications, and wound leak. So the 5-FU is more epitheliotoxic and MMC is more endotheliotoxic. So you have to be very careful and watchful if any corneal complications are there. So if the bleb is hot, that is highly vascular, then consider single injection of MMC. You can give a subconjunctival injection or multiple injections of 5-FU every day or alternate day up to a maximum of 5 injections, or else proceed with the bleb needling combined with subconjunctival MMC. Always watch for bleb features when you are using the antimetabolite and also the cornea. So coming to the bleb needling, these are the indications which I had already mentioned. So what is the goal? It is to re-establish the fistula from the anterior chamber to the subconjunctival space where aqueous humor may be reabsorbed. So this is a short video I'm doing this needling procedure in the OPD. You basically inject a 30 gauge, 26 gauge needle or a 27 gauge needle, 5 millimeter lateral to the lateral edge of the bleb. With the to and fro motion, try to cut all this fibrous septae. Once you have cut the fibrous septa, you can enter the subscleral space. Only criteria being you have to be patient, your patient has to be very cooperative, and your attendant should be very attentive when they are holding the head of this patient. The patient has to be highly cooperative, because if he moves his eyes, there can be a vessel damage, there can be intrableb hematoma or bleeding. You can see in this, it has occurred. So always try to avoid these vessels, but most of the time these are highly vascular blebs, so you can't prevent it. But this is one of the way you can see the pre-bleb and the post-bleb picture, how does it look. This is another case of bleb needling being performed in the OR. This is combined with subconjunctival injection of antimetabolite, that is MMC. So corneal stay suture is taken and the eye is rotated downwards so as to have an adequate exposure. So why adequate exposure? Because once you have exposed the superior part and as much posterior part of the bleb as possible, you inject 0.02 milligram of 0.1 ml of MMC. After waiting period of 4 to 5 minutes, you can proceed with the needling. And till this waiting period, if any mitomycin is coming forward because of the eye movement, or if you are doing under the block, but because of the structure of the eyeball, you always brush it out or iron out the whole mitomycin posteriorly as much as possible. So after a waiting period of 4 to 5 minutes, then with the help of a 26 gauge needle, which is bent like an hydrocannula, you enter from the lateral margin of the bleb, 5 millimeters away from the lateral margin of the bleb. With a cutting to and fro motion, try to cut all the septates. Sometimes you feel that they are cutting very easily. Sometimes you might feel that there is a lot of resistance, you get a lot of gritty sensation. So once you are cut throughout, you have to go till the other side of the bleb also. It is not that you start from one side and just reach the scleral flap and go behind the scleral flap. You have to make sure that you go from one side till the other side of the bleb, then come behind again, then go behind the scleral flap, and from the scleral flap into the internal ostium into the antechamber. So once you have entered the antechamber, there will be an aqueous gush, and you will see that the bleb is being formed, and there will be an AC collapse also. So you should be ready to form the AC with the help of a side port. You can see that side port entry is done, and fluid is injected to see the patency of the internal ostium, and you can see the bleb is nicely formed, and then the side port is closed by stromal hydration. So this was 1 week follow-up. Basically, this was a flat bleb, 1 week follow-up after the needling. You can see multiple cysts are there, and this is the 6 months follow-up. That is a diffuse bleb which is formed. So change in the appearance of the bleb is very important, and needling can be accompanied with antimetabolites, which I showed. Digital massage is very important. So the key to successful post-operative management is basically the early recognition of the failing bleb and correct selection and timing of these various intervention options which are available. Thank you.
Thank you. Excellent talk, MS sir. Very nice videos. So next speaker is Dr. Inda Durai. She is a senior consultant at Arvind Eye Hospital, Madurai, and she is going to speak on how to diagnose failing bleb and role of ASOCT. Over to you, Dr. Indra.
Good afternoon, everyone. At the outset, I'd like to thank Dr. Devendra sir for this opportunity. I'll be discussing about the role of anti-receptor OCT in the identifying failing blebs. So, as mentioned by previous speakers, trabeculectomy continues to be the gold standard in the surgical management of glaucoma, the success of which depends on the formation of a functioning filtering bleb. Therefore, bleb morphology is an important predictor for a successful surgical outcome, as it is considered as an indicator of shunt function and also as a predictor of bleb-related complications. Clinically, bleb appearance can be classified as diffuse, cystic, encapsulated, and flattened. A good intraocular pressure control, that is an IOP of less than 21 millimeter of mercury after filtration surgery, is usually associated with a low-lying diffuse bleb. So bleb morphology can be clinically evaluated by various methods, such as slit lamp examination and photography, and imaging methods such as ultrasound biomicroscopy and anterior segment optical coherence tomography. A careful slit lamp examination is important for the evaluation of a filtering bleb function and also for recognizing signs of early bleb failure. An ideal functioning bleb has a diffuse and a slightly elevated appearance. It is avascular and transparent and is characterized by a presence of microcysts, whereas a failing bleb is characterized by decrease in the bleb height. They may have a flat appearance, vascularization of the bleb, or the appearance of corkscrew vessels, and loss of conjunctival microcysts. They may present as an encapsulated bleb or a tenon cyst and are usually associated with a raised intraocular pressure. So ultrasound biomicroscopy enables the visualization of internal structures of the bleb, such as the formation of a cavernous fluid-filled space and intrableb reflectivity. The UBM has a 91% sensitivity for predicting functioning blebs, but only about 70% specificity for predicting non-functioning blebs. Thus, the anterior segment OCT has been used to correlate bleb structure and function, showing morphological features that can help distinguish between a successful and failed bleb. So anterior segment OCT was first demonstrated in 1994. It provides a cross-sectional three-dimensional image. It's a non-contact high-resolution imaging modality with an axial resolution in the range of 3 to 20 micrometers. Excuse me. The principle of OCT is based on low coherence interferometry, and which measures the delay and intensity of backscattered infrared light using a superluminescent diode, and it provides about 6 millimeter tissue penetration. The posterior segment OCT usually uses a lower wavelength of light, that is at 830 nanometer, whereas an anterior segment OCT uses a higher wavelength, that is at 1310 nanometer. So anterior segment OCT provides critical information about internal structure of the bleb, such as the images of the bleb wall, cavity, flap, and the ostium. It can image the intrascleral lake seen in non-penetrating glaucoma surgeries and implants used in glaucoma drainage devices. Early post-operative morphological features have also been described by anterior segment OCT that can help to predict late bleb failure, that can guide the ophthalmologist in performing interventions such as needling and suturelysis at an appropriate time in order to optimize bleb function. So anterior segment OCT is preferred over slit lamp examination as it provides an objective assessment of the bleb morphology and function. The slit lamp examination does not show internal structures, which is important not only in determining the bleb function, but can also provide information about wound healing process after trabeculectomy. AIOC has several advantages over UBM, such as it is a non-contact procedure. Therefore, a coupling fluid is not required and can be performed in a supine position. And also, as such, it does not carry any risk of bleb infection, which is an important feature which can be used in the early post-operative period. It also provides a higher axial resolution compared to UBM, and it has a high scan speed and therefore less time consuming. Time domain anterior segment OCT is preferred over spectral domain OCT for assessing bleb function, as it penetrates more deeply into the sclera. So anterior segment OCT examination provides assessment of both quantitative and qualitative parameters. The quantitative assessment by AIOC provides information such as the bleb wall thickness, the bleb height, bleb pattern in terms of microcysts, presence of subconjunctival separation, and multiple internal layers, and the height and extent of internal cavity. The qualitative assessment by AIOC can provide information about the presence or absence of bleb wall thickening, bleb wall reflectivity, presence of microcysts, which is seen as small round hypodense spaces in the surface of the bleb, and also information about the bleb cavity, ostium, scleral flap, and the subflap space. So anterior segment OCT can be used to differentiate between functioning and failing bleb, either based on the global appearance and or based on the bleb wall reflectivity and or based on the internal bleb morphology. So based on the global appearance, blebs with a diffuse or a cystic morphology have been identified as a functioning bleb, and those with an encapsulated or a flattened appearance have been identified as a non-functioning bleb. So this is a OCT image of a diffuse filtering bleb. This is characterized by the presence of subconjunctival fluid-filled space collections with a low to moderate intrableb reflectivity. The cystic bleb is composed of a large hyperreflective area which is filled with a multiple fluid collections of varying size and intensity. The encapsulated bleb has a fluid-filled space surrounded by a connective tissue with a very high signal reflectivity. Flattened bleb does not show any bleb elevation, but it has high scleral reflectivity, and the outline of the scleral flap and sclerotomy were identified. So based on the bleb wall reflectivity, the blebs were classified as those having uniform or multiform reflectivity. So blebs with an uniform reflectivity were characterized by the absence of fluid-filled hyperreflective spaces in the subconjunctival space. They were seen as smooth hyperreflective wall, and these blebs showed increased chances of failure, whereas blebs with multiform reflectivity showed presence of small multiple fluid-filled spaces, which were seen as hyporeflective areas in the conjunctiva, and these blebs were associated with an increased chances of success. So based on the internal bleb morphology, the functioning bleb had the following characteristics on AIOC. a visible root beneath the scleral flap, conjunctival thickening and subconjunctival fluid collections suggesting adequate aqueous humor drainage and a better IOP control, presence of a large internal fluid-filled cavity, which is seen as an extensive hyporeflective area, thicker and higher bleb balls with more microcysts, and multiform bleb ball reflectivity were found to be good indicators of bleb function. Uniform blebs with no signs of fluid were found to be associated with a higher intraocular pressure, especially during the early post-operative period. Narrow widths and filtration openings on the scleral flap, low bleb ball, thickening of the bleb ball which was typically absent, ostium occlusion, and high reflectivity between the conjunctiva and the scleral flap were features of a failing bleb on AIOCT. This AIOCT had few limitations, such as the disability to image bleb vascularity, and it does not provide microscopic information such as epithelial stromal microcysts as seen in confocal microscopy. And features indicative of bleb inflammation or infection could not be detected by this modality. So thus to conclude, AIOCT proved valuable in the early identification of signs of failure, which was critical for bleb management, and the reflective appearance of bleb ball and width of filtration opening, which was analyzed by AIOCT, were considered important predictors of post-trabeculectomy outcomes. Combining both the clinical and imaging information could provide a new perspective towards understanding the different surgical outcomes after trabeculectomy, and this is important to refine surgical techniques and evaluate different adjuvant treatments in surgical management of glaucoma patients. Thank you.
Thank you, Indra. Very nice talk.
I now request Dr. Devendra Maheshwari to give his talk on nuances in surgical techniques of bleb needling with MMC. Thank you.
So good afternoon, everyone. First of all, I would like to thank Scientific Committee AIOS for giving this opportunity. So today I'm going to talk about the nuance in surgical technique and the bleb needling with MMC. As all we know that doing a trabeculectomy is half job is done. So trabeculectomy is quite simple surgery, anybody can do. But really managing the post-operative part of the trabeculectomy is need a little bit skill and really have to be patient to get the optimum outcome of the trabeculectomy. So when we have tried all the measures and we find out our trab is not going to work, that time we should consider such process called the bleb needling. So basic aim of the bleb needling to re-establish the fistula from anterior chamber to the subconjunctival space through the aqueous humor may reabsorbed. So first step, recognize the failing bleb, though Dr. Indra and Dr. Amit have nicely described. So these kinds of bleb as looking like the failing bleb, and this is the elevated smooth dome shape, fibrotic bleb, and loss of the microcyst, and the red vascular looking blebs. So they are the early sign of the failing bleb. So now focus on to the more common cause of the trabeculectomy failure. Most common cause either the subconjunctival fibrosis or subtenon encapsulation. Now coming to the where is the main cause of the failure of bleb failure. So basically bleb fail, either the capsule is at the level of the capsule where the subconjunctival or episcleral fibrosis is going to happen. So at the time we have to do the modulation for this as described by the Dr. Amit. And second site is the skull flap. So the under the subscleral fibrosis is going to happen or your ostium has been closed. So recognizing the failing mirror as we all described. So before deciding for bleb needling, as Dr. Amit has already talked about it, do all the conservative measurement like the vigorous ocular distal massage, topical steroid, enhance the steroid more, do the sutural lysis one by one, and sometimes it's helpful to add into the dorzolamide or ecosapressant in the early post-op period for the bleb maturation. And recently we can apply this like 5-fluorouracil. You can inject the injection mitomycin C in early post-op period to establish the bleb or functioning of the bleb. That everything is fails, then the next step is become the surgical intervention that is called the bleb needling. So what are the indication of the bleb needling? There is a episcleral scarring, unresponsive to conservative management, and excessive scarring or encapsulation of the bleb, and elevated IOP with deep anterior chamber. So before starting the surgery, certain point we have to consider. First of all, we have to do the gonioscopy to look into the internal ostium, either it's open or not. There must be some residual function in the bleb. Blab needling is not going to work when it's fully scarred. There definitely some kind of the conjunctival elevation will be there. Go for the preoperatively, check the conjunctival mobility before doing for the blab needling. And patients should not be on anticoagulant. So before doing like any surgery, really is need the good counseling. Good counseling is more required because the patient undergone already the unrewarding surgery. We call the trap is unrewarding surgery. Patient hardly going to appreciate you when you do the trap. His vision is going to drop down for 1 month, 1.5 months. So really, when you're doing the second intervention to the patient, really we have to talk with him, explain him why we need this surgery and why again you have to go to the operating room. I may be required, you again require some kind of medication even after the procedure also, and you may require the further surgery also. So before doing the blab needling, patient has to be counseled for everything, what you think, what will be the outcome of your blab needling. Then coming to the what instrument you want to use for the blab needling. Either you can use 26 gauge needle, 27 gauge needle, 30 gauge needle, even the MBR blade. So best option there, whatever you do in routine practice in one thing. If you're using 26, always use 26. If MBR work in your hand, go for the MBR. Don't change your instrument for the blab needling. So this is the various studies have shown, either we can use the subconjunctival mitomycin C or 5-FU. So the various studies has shown the subconjunctival mitomycin injection has a favorable outcome in compared to the 5-FU uracil. So the technique of the blab needling. So first of all, either we can do in slit lamp or the operating room, as Dr. Amit has described. But always when you want to do in the slit lamp, always prefer to do the sum of the blab needling in your operating room. Really, it need really very, very good cooperation of the patient when you are going to do into the OPD procedure. And sometimes patient really squeeze the eye and really is difficult to do. So you have to master in doing blab needling, then you can try in your OPD procedure. First, either use of topical or the peripheral anesthesia. Prefer the peripheral anesthesia because we are entering into the anterior chamber, so the patient will literally have the pain. An antibiotic drop has to be started before to the procedure, and the 5% probably in iodine to avoid such kind of infection, because we already having the one fistula in the eye and again creating the one more to making patent. And the brimodine is going to help for the vasoconstriction and it reduce the bleeding during the procedure. Similar way, the adrenal swab we can use where we want to make the entry that avoid the bleeding. So this is the way we are doing the video of the blab needling. So after injecting the mitomycin C 5 to 6 millimeter away, bend your needle around the 45 degree, so that give you the adequate exposure. When you enter into that blab, you should know where you're going. Your needle should be along the globe. It should not be away from that, it should be along the globe. And after cutting the subconjunctival fibrosis, we try to lift the flap. So I'm now working on my hair, so going into the flap. After going into the flap, then you enter the anterior chamber. Once you enter the anterior chamber, you feel the traction of suture is become the loose because the globe become a soft. Once soft is there, the patency has been maintained. Then you make the anterior chamber with balanced salt solution. This is the new blab needling, especially in phakic eyes. So phakic eyes, little bit, we have to take little extra precaution. Similar way, we have to inject our mitomycin C. After injecting the mitomycin C, wait for the 4 to 5 minutes, and then take the good traction corneal suture. So this will help us. And because it's a phakic eye, make the side port. After making the side port, enter the anterior chamber maintainer, so it don't collapse your eye because the phakic lens is there. And similar way, you can use this needle And again, this time I went from other side because there's a lot of thick fibrous capsule around the hair. So literally when you do in such eyes, really the young age, especially the fibrosis is so thick, we have to cut so many times. Sometimes if I'm not able to move here, so I'm going to cutting here again. Here is a kind of ring of steel has been made. So a repeated attempt is required to cut it. But again, remember, you should not, your needle should always follow the globe. Then here, I am not able to do, then I am trying from the other side because that is excessive fibrosis is here. Once I cut it, then my AC becomes soft and you see the huge blab has been formed. This is another method of doing blab needling with a spatula. This kind of blab needling is going to helpful when we are having the scleral fibrosis. So after the injecting mitomycin C, similar way that we seen in the previous videos, they say one side port has been made, and you can inject a viscoelastic. So it's mostly is considered in pseudophakic eye. This is the spatula I'm showing. This is called the Devendra Grover's spatula, and this spatula through the side port has been entered under the flap, and once you go to under the flap, then come to the subconjunctival space. So you can see my spatula is moving here, like here, similar way. Or we can use in such blab needling, we can use the direct gonio lens, so we can assess the ostium. So again, this is my spatula is moving here. But again, this technique is good, but less chance of bleeding, but little learning curve. And at the end of surgery, you can see the nice blab has been formed. So the advantage of now coming to the advantage of blab needling on the slit lamp, really outdoor procedure, patient will be always happy because he no need to go for the option theater. It's cost effective also, and there's no psychological trauma also. And the little inconvenience and time consuming. So when we are considering the blab needling in OR, really it has some advantage, but we should keep in mind all these factors. Patient has to be very, very cooperative, and you have to explain the procedure to the patient, what you are going to do. The similar way, the cotton tip applicator has been soaked in the topical anesthetic, has been applied for the 2 minutes before the procedure. So this is good adequate anesthesia should be there. Then place the lid speculum and counsel the patient. Really we need one assistant to hold the head and elevate sometime the lane. And this is the very important here. Don't try to do the subconjunctival fibrosis, remove the subconjunctival fibrosis, because the high chances are there you can make the hole into the conjunctiva. So try to lift the flap first. Once we lift the flap first, then some amount of the aqueous egress, then this aqueous will help us to elevate the blab, and thus we can move the needle thoroughly over the blab. So this is the technique developed by the transcorneal needling by the Paul Pomberg. It is a quite non-invasive technique. In this technique, the 30-gauge needle bend like a jet-shaped manner, and that needle has to be passed into the needle has been passed through the needle has been passed through the cornea here, through the cornea self-sealing wound, through the self-sealing wound, go to the ostium, through the ostium, it has been come into the subconjunctival space. So there is a good technique, but really it has the quite learning curve. So which case the blab needling is not going to burr, because we should know what is not going to burr before doing it. So if the pre-op IOP is more than 10 mmHg, less like to burr. Trabectomy without mitomycin C, immediate IOP more than 10 mmHg, and after the 4 months of the trabectomy. Though this is a little controversial, some of the study says we can do the blab needling even after the years and showing some kind of good result. But it depends upon what works in your hand, but we don't prefer the late blab needling. Our results are not good. After doing the post-operative, always go for the thorough settle lamp examination, check for the settle test after the 30 minutes of the procedure, and give the topical steroid. Really, we need to enhance the steroid also. At least give for the antibiotic for 1 week to 2 weeks, but the steroid dose has to be increased. So like any other procedure, trabeculectomy, blab needling also have some complication like the intra-blab bleeding, hyphema, hypotony, choroid detachment, malignant glaucoma, blebitis. These are the some complications we should keep in mind. So just to conclude, blab needling can rescue the failing blab and save the patient burden of the using multiple anti-glaucoma medication and repeat surgery. Blab needling should be considered when blab fails post-surgery. Needling does not affect the outcome of future surgeries. In addition, needling converts the failed blab into the more diffuse blab, which reduces the risk of the blab leakage and late complication. Thank you for patient listening.
Thank you, Dr. Devendra. Very nice talk on blab needling with mitomycin.
Sir.
Next, I will request Dr. Ganesh Raman again, needling of the blab with collagen implants. So to go about it.
Thank you, sir. Thank you, Dr. Devendra, Dr. Ravindra for inviting me here for this session. I'll be speaking to you on bleb needling in collagen repeat trabeculectomy, which requires extra care. Collagen, as you all know, now it's of course not available. It may be available soon because of the COVID-19 issues. Production has been affected. But before COVID, we used to use this quite extensively, especially in situations which require the avoidance of mitomycin C. For example, high myopes or traumatic glaucoma, patients with rheumatoid arthritis. It used to be an alternative to mitomycin C. It induces anti-scarring properties without chemical inhibition and results in prominent filtering bleb with successful surgical outcome. It's very biocompatible, biodegradable, and comes in a ready-to-use pack. So there's no need for preparation or any such procedure prior to usage of collagen. And how one uses it is that after the scleral flap has been created and you have done your ostium and the iridectomy, you suture the flap and keep the collagen over the flap, sutured flap, like here. And once you have done it, then you suture the conjunctiva. And the collagen acts as a buttress. It prevents shallowing of the chamber because it allows aqueous percolation in a limited area, limited way, and doesn't allow sudden gush of aqueous. The only disadvantage with the usage of collagen is one is compulsorily required to use releasable sutures because you cannot do a argon laser suture lysis if you were to use collagen, because you cannot view the sutures once collagen has been placed. So that was one of the disadvantages. And a couple of studies which mentioned that collagen matrix efficacy and compared to mitomycin C. So collagen eyes required more bleb needling compared to mitomycin C. So that's one of the trade-off which you have to do. But the advantage is that you don't get the mitomycin C related complication, late complication like cystic bleb formation with collagen. And bleb needling with collagen, the most important thing is to avoid mitomycin C. So you would have seen all the bleb needling which was done before. And if you don't have a history of proper history from the patient, whether collagen has been used or not, it's better not to use mitomycin C. So that the mitomycin C will seep into the collagen, get absorbed, and you'll have late complications of congenital melting. So here we are doing bleb needling. You see the collagen tissue, which is conjunctival tissue. I'll just start from the beginning again. And this area is not filtering. You have a dense scar, and the collagen disc, which I showed previously, is just sitting there. It's desiccated, and the aqueous flow is not present. So what we have done here is we used an AC maintainer. You could also use AC maintainer. So that gives you a good idea that the aqueous flow, which is going to happen, will happen under a pressurized manner. So the moment you enter the anterior chamber, you will find that the pressurized fluid from the anterior chamber comes through the ostium into the subconjunctival space and balloons the conjunctiva. So that's your end point. You can do it from your if you're right-handed, you can do it from the right side, and also you can change position and do it from the left side also. So another technique is to use a AC maintainer. And once you have entered the antechamber, so this is known as the needle revision of the bleb. So bleb needling is when you just needle the bleb, and that's it. Once you enter the chamber, you are revising the bleb. You are making a separate ostium, a larger ostium, changing the ostium, and allow more aqueous to come inside. So AC maintainer will help you to gain an endpoint, and once the needle is coming out of the ostium, you'll find that the conjunctiva balloons up very nicely, and you will have a little bit of regurgitant reflux of blood into the antechamber. The eyeball will be always soft initially, so you cannot make it really firm as you would do in your phaco incisions or cataract surgery. And also it's better to go a little posteriorly as much as possible. And post-operatively, as Dr. Devendra has shown, we use a lot of steroids. Sometimes I use even 1 hourly steroids for the first 1 or 2 days, and then tapers subsequently. Repeat trabeculectomy is another procedure which you can follow. As Dr. Devendra mentioned, more than IOP more than 30 millimeters mercury, you wouldn't like to do a bleb needling. So this is from the Shankar Nethralaya group, in which they had a repeat trabeculectomy which was done, and they had complete success in about 60% when a strict criteria was implemented, and 40% when a 60% when liberal criteria was input, and then criteria C when you have a strict criteria. So you can achieve about 40 to 60% success if you do a repeat trabeculectomy. So causes of failure, if the duration of surgery is less than 4 years. So supposing a primary trab has worked for 4 years, you could think of doing a repeat trab. But if your trab has failed within 4 years, then better to do some alternative procedure. Secondary glaucomas, definitely the repeat trab is difficult to make it survive. Younger age group, phaco trab and phonics-based trabs are other risk factors for failure. So from the Madurai Arvind group, Dr. Krishnas, Dr. Sharmila has published a success of the repeat trab at the end of 12 months, which shows that the mean number of drops and the mean intraocular pressure was quite significantly less when they did a repeat trab. So the important thing is to check for the conjunctiva. So you have a scarred conjunctiva, so that's a strict no-no for repeat trab. Or you should have a mobile conjunctiva like this, so that you can get good successful. So test for the conjunctival mobility before planning for surgery in such situations. Repeat trab, the principles are almost the same. There's not too much of a difference. You see the superior trab is that we're planning a supronasal procedure, and we use a superior rectus bridle suture. And then conjunctival dissection is the same. We make deep pockets supranasally so that the aqueous has good outflow. And after conjunctival dissection and cauterization, make sure that the episcleral tissue is all dissected. And we use mitomycin C. Sometimes we use for longer period of time, about 4 minutes, 0.2 milligram per deciliter. And then in this, we take a calculated risk because we don't want to have the same failure rate as we see in the primary trab. So we use a little bit of larger ostium and releasable suture more number of releasable sutures. And once all the sutures will be invariably releasable sutures. So once you have sutured the flap using releasable sutures, then we close the conjunctiva as conventionally. There's not too much of a difference. The only thing is post-operatively we'll be calling them more frequently and make sure that the take certain steps, increasing steroids to make sure that the bleb survives much better. And sometimes you may even do an infratemporal trab in certain situations, although not generally recommended, but in a case-to-case basis in a patient who has very good follow-up. So this was done infratemporally with a releasable suture, and you can see that the releasable suture can be pulled out. So a very rare situation, infratemporal trabs usually not recommended because of high incidence of endophthalmitis, but this was certain situation where we did not have the RD implant long time back, and we did certain infratemporal trabs. So points to be considered: difference between the primary trab and repeat trab should be more than 4 years. Secondary glaucomas, check for conjunctival site availability and anterior chamber distortion. Younger age, fornix-based flap, phaco trab, and try to use, these are all high risk for failure, and try to use mitomycin C for longer duration of time rather than more concentration. Thank you very much.
Thank you, Ganesh, for excellent talk. We can say something, yeah, we can take the only 1 or 2 questions. Yeah, please carry on.
The first one is that a basic question, that what should be the follow-up schedule for the patient who has undergone trabeculectomy, and when should we decide that we need to do, if it has failed, we need to do needling, like after how much period of time?
Usually, if you look for the trab follow-up, ideally we look after the first post-op day, then after 1 week, then every weekly for at least 1 month, then after that 2 weekly for the next month. And apart from the timing of the blab needling, usually we have to consider the most of the sequential suturolysis. So at least for first visit you can do cut only one suture, the next week 1 suture. So at least for blab needling we should wait 3 to 4 weeks. Makes better to do blab needling after 4 weeks, gives the good outcome and reduce the further complications like blab needling we associated. Yeah.
So another one is that there are 2 scenarios. One is there is a new vascular glaucoma after a patient who has had CRVO. We have done a PRP, now there is minimal NVI. This is one patient. Another patient where NVI is still more. Now what should be the option for a patient where there is a minimal NVI, we can just see a bit. Should we go for a trap? Can we go if the IOP is still high? If it is still after medications also, if it is still nearing somewhere around plus 25 millimeter of mercury. And another scenario where there is lots of NVI and IOP is still high. So where to go for an implant and where to go for a trap?
I think RK sir, would you like to answer this? Okay, so I think this beyond of my IC, but still I would like to answer. So it depend upon if you really very good at a trap, you can try with minimal NBI, you can try with high use or high dose of metabolite, you can use your trap in neovascular glaucoma, but again explain the patient, really there's a high chance of the failure. When you talk about the second scenario, with a lot of NBI is there, so first thing, do the thorough PRP, and do the anti-VGF, then you go for the implant. They are the good success. But again, the problem is this, if you are good in implant, then only go for the implant. If you are not good at, refer to someone else, or you can try your trap.
Yeah, I think I'll just add, if you are able to see the gonio, if you see that open angle is there, you can do a trap directly, mainly because it will reduce the IOP from day 1, and you can hand it over to retina colleagues for PRP. Because that's why you still have continuous to have
so actually, I'm talking about a patient here who has done, where we have done the PRP and still there is a lot of...
Yeah, if you see the angle, do a trap. If you see the open angle, do a trap. If you don't see the angle open, then do a tube in which you put the tube in the sulcus. You know, because that iris, if you try to overcome it, it's going to definitely rub against the cornea, have micro movements and cause corneal decompensation later on. So sulcus is a huge place. It's not a very small space as we think. A huge space can accommodate a tube very comfortably.
Thank you. Thank you for all co-instructor, and thank you for it.